Hello, everyone. My name is Dr. Jodie Guest. I'm an infectious disease epidemiologist and professor and vice chair in the Department of Epidemiology at Rollins School of Public Health here at Emory University. I lead Emory's COVID-19 outbreak response team working in harder hit communities across the state of Georgia to provide vaccinations and testing. And I am the host for COVID-19 Facebook Live events at Emory University, where we cover important topics about the COVID-19 pandemic. Today, I'm very pleased to be joined by my friend and colleague, Dr. Carlos Del Rio. Dr. Del Rio is a distinguished professor of medicine, epidemiology, and global health at Emory University, and is the Executive Associate Dean of Emory University School of Medicine at Grady Health System. Dr. Del Rio also co-directs the Emory Center for AIDS Research and is the Foreign Secretary of the National Academy of Medicine. Dr. Del Rio was named one of the 30 most important immigrants in the United States by the Carnegie Corporation this year as well. Welcome, Dr. Del Rio, and thank you so much for joining me today.
Happy to be with you as always.
There's been a lot of new information about the COVID-19 vaccines in the past 2 weeks. So today we're going to try to cover all of that, including reviewing booster approvals and data, pediatric vaccines, and we're going to talk about the COVID-19 pandemic just generally. Where are we now at this time as we approach the Thanksgiving holidays? So let's begin today talking about the new approval of the Pfizer vaccine for children aged 5 to 11. With a vote of 14-0 in favor of vaccinating all kids 5 to 11, it was clear watching the CDC's Advisory Committee on Immunization and Practices meeting that the data show that they believe that the kids 5 to 11 are better off vaccinated. As a bit of background information, more than 1.9 million children in this age group have been infected with COVID-19. 8,300 have been hospitalized due to COVID-19, and 94 that we know of have died from COVID-19, making this the 8th leading cause of death for 5 to 11-year-olds this year. Beyond that, we do have concerns with long COVID, missing school, and the fact that the children are actually a driver for community transmission. These are all large concerns that we have for children in this age group with COVID-19. So Dr. Del Rio, what were your thoughts as you watched the vote that the CDC affirmed right afterwards that night, finalizing the approval for this vaccine for children aged 5 to 11?
Well, first of all, I was very excited, but I'm also just elated about how far we've come and how quickly we've come. I mean, it's only last January when we started rolling out these vaccines to very high-risk individuals, right? They were first approved in December. I've had the fortune of getting vaccinated with the Pfizer vaccine back in last December and getting my second dose in January. But we are, 10 months later and 11 months later, and now we are having vaccines for 5 to 11 years old. Who would have imagined? And that's a result primarily of clinical research and how hard clinical investigators, including my colleagues here at Emory, have worked to do the clinical trials to create the data that has now led to these approvals.
Absolutely. So much good science has been done in this period of time. During this meeting, one of the most important conversations that I think happened was when the CDC gave a very important comparison. We vaccinate for diseases that have far fewer deaths and hospitalizations than COVID-19. One example that they gave for children was hepatitis A. Prior to the vaccines for hepatitis A, there were on average 3 pediatric deaths a year. And we compare that to COVID-19 with an annual average of 66 deaths in this age group before vaccines. How important was that conversation?
I think it's a very important conversation, and everybody, including myself, when you think about giving anything to yourself, to your family members, to your loved ones, to your kids, you think about risk-benefit ratio, right? And with the current amount of transmission we're seeing in our community, if you vaccinate 1 million children between the age of 5 and 11, you will prevent about 45,000 infections. You will prevent about 192 hospitalizations from COVID and about 1 death. Contrary to that, everybody's concerned about, well, what's the risk of myocarditis? Well, if you give 1 million vaccines, you will probably see about 100 cases of myocarditis. You're going to see about 58 of those 100 cases being hospitalized, and you're not going to see any deaths from myocarditis. So the risk-benefit ratio favors the vaccines. And again, it is all about really thinking about, what are the risk benefits, and the risk-benefit ratio overwhelmingly supports giving the vaccine.
And it supports giving the vaccine to children regardless of whether or not they've had an infection with COVID-19 or any underlying conditions. And in fact, they showed some really incredible data saying that about 38% of the kids that they tested in this age group had detectable antibodies from natural infection. And what they suggested was that this is higher than the estimate among adults, but we've also seen some data that natural immunity on a population level is insufficient in protecting our kids. And because of this, the recommendation was that children, regardless of previously having COVID-19, should also be vaccinated. Can you walk us through some of the reasons for the variability that we see in natural immunity?
Well, it's something that we still need to understand. It's clear that natural immunity has some protection. And it's clear that you have better protection, but it's very variable level of protection. The older you are, men, people that have been hospitalized are more likely to have more robust immune response from natural infection than people that don't have those characteristics. So for example, I have a friend who is in her 40s who had COVID and yet had developed no natural immunity. So it could clearly happen. It's very variable, the degree of immunity. A lot of kids may develop antibodies, but may not have sufficient antibodies to develop natural immunity. So the older you are, the more likely you are protected from natural immunity. And the data suggests that your protection is probably for about 6 months. It's pretty good for about 6 months. And that's why when somebody who's been, somebody in their 60s who had COVID and was in the hospital says to me, do I need to get vaccinated? I said, you can wait 6 months. You're probably better off waiting and getting vaccinated right away. But in children, it's a little different because a lot of those kids were probably asymptomatic or minimally symptomatic with their infection. And it's very unlikely they have the level of robust immunity that you need that the vaccine is capable of producing. Now, we do know that if you've had COVID and you get vaccinated, you have the best possible immunity. So even a better reason to get your vaccine after you had COVID is that you really want to have that protection that is better than none. And this will go on to a conversation we'll have later on about boosters. A question frequently I get is, I had COVID, I got vaccinated, do I get a booster? The answer is you probably don't need a booster. You already have been boosted.
But we don't want anyone to go out and get COVID-19 in order to get a natural booster, for sure.
Oh, no, absolutely. But you may get COVID. And again, I tell people with the amount of COVID in our communities, you will encounter COVID and you're better off when COVID finds you, you're better off if you're vaccinated than if you're unvaccinated.
Absolutely. Let's move on to these adult data that you were already leading us towards. 58% of the US population is now fully vaccinated, and 67% have received at least one dose of a COVID-19 vaccine. And now we have another 28 million children who are eligible for these COVID-19 vaccines in this 5 to 11-year-old age group. So boosters were part of the FDA and CDC review several weeks ago. Across all the different meetings that reviewed these data that were public meetings, the message was clear. Boosters are safe, they are effective, and they are needed for some. Let's start first with the who should get a booster, and then we're going to move on to some of the really interesting data about mixing of boosters. So really, in your opinion, who needs to get a booster and how soon do they need to get it?
So if you look at what CDC, the ACIP put out, is there's a should and there's a may.
Mm-hmm.
The people that should get a booster are people over the age of 65. The people under the age 65 who have an underlying condition like diabetes, obesity, hypertension, and then HIV disease. And then you get to the people that receive the Johnson & Johnson vaccine, anybody that received the Johnson & Johnson vaccine. For those that receive the Johnson & Johnson vaccine, the booster should be 2 months after your original vaccination. For the people that receive the mRNA vaccines, the Pfizer or the Moderna vaccine, should be somewhere between 6 and 8 months after your original completion of the original series of vaccines. Now, there's the may category, and the may receive a booster is pretty much everybody else. And for example, healthcare workers, grocery store workers, anybody who, because of their occupation, they're at high risk. Teachers, they're at high risk of exposure to COVID. Is eligible to get a booster. And the reality is, in our country, pretty much anybody who wants a booster can get a booster. It's pretty, we have a lot of vaccine availability, and we are fortunate to have a lot of vaccine availability. In a lot of the world, people are still waiting to be vaccinated.
Right.
I mean, I looked at the numbers, you said, most developed countries now, over 60% of the population is vaccinated. In most lower income countries, less than 3% of their population is vaccinated. So we are very fortunate in our country, but I'm also very surprised that there's so much vaccine availability and so little demand at this point.
That is true. There was a really incredibly interesting set of data that came out of a clinical trial that did the very first mixing of boosters with primary vaccine series. And the biggest benefit came from those who had received Johnson & Johnson as their primary vaccine. So let's talk through every single option of a primary vaccine and what the data showed about your best possible booster following that. So we're going to start with Johnson & Johnson, where it was clear that the data showed that Moderna was the best booster and provided the most benefit. What exactly was the benefit seen with the Johnson & Johnson primary vaccine?
Well, let me just say that, I was involved in that study. My colleagues were involved in that study. That's an NIH-funded study that we did through something called the ICDRC, which Emory is the lead in that grant. It was a study really to look at safety and immunogenicity. So first of all, we know that no matter what you got vaccinated with, no matter what you get, it is safe. The number two thing we learned, it is immunogenic. Now, some vaccines, when you boost, are more immunogenic than others, but we don't really know that translates into clinical benefit. So we need to be careful when we say, oh, this vaccine, this boost is better than another, because the reality is we don't really know the translation into clinical benefit. I would say any booster is better than no booster because you will get an immune response, and any booster is safe to get. The advantage of this, really, the most important thing about the mix and match study is that you don't need to go out there finding the vaccine you got. So if you got J&J right now and you try to find J&J, you may not find it. There's not a lot of J&J availability, but there's plenty of Pfizer and there's some Moderna availability. So that means you can get boosted with whatever is available, and the most available vaccine is Pfizer. So I would not necessarily choose a booster based on, oh, this looks better than this, because the reality is they all very good. But I would do it in the sense of what's available. What can I get the day I need my booster? And in that sense, the data suggests that whatever you get is better than nothing. Now, if you got a J&J vaccine, I would probably recommend you get an mRNA booster.
And it doesn't matter which of the two mRNA boosters that you get when you follow.
I don't think so. I mean, I think, again, Moderna looks better, but Moderna is 3 times the dose of Pfizer, right? You get 100 micrograms in an original boost, 50 micrograms in an original vaccine, 50 micrograms in a boost, versus Pfizer, which is 30 micrograms. So there is a difference in the dose that may lead to a better immune response. But again, we don't really know what the translation of that higher immune response into clinical benefit really is.
So let's put the other two vaccines together. If you started with a primary series of an mRNA, either Moderna or Pfizer, should you stick with an mRNA vaccine for a booster, or should you move to Johnson & Johnson?
I would stick with an mRNA vaccine for a booster. The data suggests that you could get a Johnson & Johnson vaccine. But again, I would suggest an mRNA vaccine because the data looks safe, and it's just also because of availability. I mean, again, you go to the website to try to find a vaccine, you're going to have a lot of trouble finding a J&J today available in Atlanta.
Is there any reason to switch the mRNA vaccine? So if I had Moderna to start with, you had Pfizer, should we be switching for our booster?
I don't think so. I don't think it's necessary. I think at the end of the day, a boost is a boost is a boost. The immune system doesn't recognize one over the other. The difference may be in the dosing, but again, the dosing of boosting of Moderna is 50 micrograms versus 30 of Pfizer, so they're pretty similar.
And so why was Moderna's booster cut in half of its original primary vaccine dose?
Well, it was based on some of the data that suggests that it's much more reactogenic at the 100 milligram dose, and it's equally immunogenic at the 50 microgram dose. So it was probably a way to decrease side effects.
Okay. And I have definitely heard that people had fewer side effects from a booster than they did from their second dose of an mRNA vaccine, which is a good thing, since some people had, although transient, had some significant malaise and fatigue and headaches after their second dose of either of the mRNA vaccines.
Yeah, that is correct. Most people have tolerated the booster just fine.
Excellent. And again, you're recommending between 6 and 8 months for the spacing of this booster after an mRNA vaccine.
Correct. But again, I want to really emphasize that the data we're looking at is that while there's waning of efficacy over time, and part of it is time, but part of it is also Delta, the efficacy of these vaccines in preventing severe disease, hospitalization, and death, even if you don't get boost, continues to be extremely good.
Very important to point out. We're going to turn to some of the more staggering numbers that we've seen come out in the last several weeks. On November 2nd, the world surpassed 5 million known deaths from COVID-19. And on November 4th, Georgia surpassed 25,000 deaths from COVID-19 since the start of the pandemic. These are both likely to be pretty significant underestimates of how much death might have been caused by COVID-19, but they are certainly a grim reminder of how much our world has gone through in the past year and a half, a little bit more than that, and how far we've come in that period of time. We now have some very good drugs to use if you are sick with COVID-19, monoclonal antibodies, molnupiravir, and we have our 3 vaccines that have been approved, at least through emergency use authorization or final approval for Pfizer in the United States. How important are these new drugs to treat COVID-19? And let's compare the use of them versus vaccines to prevent severe COVID-19.
Well, let's start by saying that even though the drugs are some of them are really good, the best thing you can do is not get infected, right? Similar to what we talked on the booster. I mean, get vaccinated, prevent. You know, we always say an ounce of prevention is worth a pound of cure. Absolutely. You know, prevent getting infected. And the way you do that is by getting vaccinated. But if you are high risk and you get infected or you haven't been vaccinated and you're high risk, you know, we really did not have a lot of therapies available. Monoclonal antibodies are really our best shot of therapeutics. And the availability, monoclonal antibodies are complicated to give. Or you have to be, you know, in a clinic, you have to be in an infusion center. There's a lot of issues around. You have to give an injection. So the availability, also the cost is not insignificant. So they offer an opportunity, but they're not a great opportunity for everybody. But the availability of oral drugs really is a game changer. And, you know, we first have the antiviral molnupiravir that was initially developed by our colleagues at Emory, George Painter and his group, which is now being tested by Merck. The data we've seen is very encouraging. And as I said, I have not yet seen the full data. We've seen really a press release, but the press release is very encouraging. I'm looking forward to see the paper and see actually what it does. But what it does is, you know, it seems to cut the risk of hospitalization and death in people that have severe disease by 50%. Now, we have a new antiviral that Pfizer gave us a press release on yesterday, which is also very encouraging, suggests that the risk of hospitalization and death in people with COVID who have high risk of progression is actually cut by 89% in those that receive this antiviral. So having available options as pills is incredibly important. Now, both of them need to be given within 5 days of diagnosis. And this is, again, the challenge. People need to get tested, and people then need to have access to medical care right away in order to get prescribed the drugs. And the access to testing is something that we need to continue working on, because the reality is testing availability has not been where we would like it to be during this pandemic in our country.
Testing availability has both been variable, how often you can find it, but it also, I don't think that there's a lot of urgency to consider getting tested anymore, the way there was a year and a half ago, when testing was so very difficult to find. And every time we had a testing event, we would have lines that would start hours before we would begin testing. And now we can be at a testing event for 4 hours and maybe see, 25 to 50 people come by to get tested. So there's a real lack of urgency among the general population about getting tested, as well as it can be difficult to find a test these days.
Well, and that's where I think a rapid tests play a role. And I wish rapid tests, today I went to the drugstore and saw a ton of rapid tests, and they're available, but they're pretty expensive. They're about $25 for a box. So it's not something available to everybody. But the reality is, if you start having the sniffles, I mean, I would have some rapid tests available at home if I could. And if you start having the sniffles or don't feel good, have a sore throat, have a cough, you can rapid test yourself right away. And it's pretty good to diagnose symptomatic disease. So if you start having symptoms and get tested, it's a good opportunity for you to then rapidly get into confirmatory testing and get into care right away. So a lot of home testing would be really a game changer for this kind of medications.
What about the Thanksgiving holidays? They are quickly approaching, and many of us could not get together or travel to see family and friends last year. It's a really different time this year than it was last year from the pandemic perspective. We now have vaccines. Last year at this time, we were really starting to see soaring cases of COVID-19, and we're coming down off of this terrible Delta surge that we have had. What would you do to prepare to both travel to visit people for Thanksgiving? And if you had people in your home, would you ask everyone to do a COVID-19 test before they came?
Well, let's put it this way. The numbers are coming down, but they're still incredibly high. I mean, we're still diagnosing, 75,000 people a day. We still have over 40,000 people hospitalized. We're still having over 1,200 people die every day in our country. So the numbers are coming down, but they're not down where I would like them to see to feel totally safe. In many states, Colorado and other states, the cases are actually going up. They're not coming down. So, I honestly still worry that COVID has not gone away. So continue thinking about mitigation. And the way you think about mitigation is, everybody that goes should be vaccinated. Some kids under 12 may not be able to get vaccinated. Well, they may not be able to have been vaccinated yet. Well, try to get most people vaccinated when you do your family gathering. Number two, if the weather allows, do it outside instead of inside. If you're going to do it inside, try to keep the window open. You got to tell everybody, if anybody has symptoms or doesn't feel good, don't come. And finally, consider doing testing. Again, it's an issue of costs, an issue of availability. But if you can afford it, you can have testing done. I would go ahead and say, 72 hours, 24 hours before the event, get tested, because it really is a good way to at least detect somebody who could be symptomatic and who could be infected and could have transmitted in that event.
It's good advice. And I want to end with something else you just brought up. We are starting to hear conversations about, have we reached our endemic level of COVID-19? Is this the place and the set of numbers that we're going to live with forever with COVID-19? And what I hear from you is, this is not an acceptable place for COVID-19 to stay endemic at this level of death and this level of hospitalizations. What else would you say about that?
Yeah, I mean, I think endemicity is going to have to be defined. I mean, we need to define what are we aiming for. I mean, at some point in time, we were aiming for COVID eradication. That's not going to happen. So we need to understand what endemicity is going to look like. And a lot of us have been talking about this. I mean, in my mind, having less than 10 cases per 100,000 population, having a positivity rate in testing under 5%, having less than 5 cases per 100,000 in the hospital, and having less than 100 deaths per day at the country level would be probably a place where I would feel very comfortable and say, hey, this is a place that we can all live in. And many countries have gotten there. Many countries like Iceland, like Denmark have gotten there and are pretty much living a normal life. I said, this is over, and the CDC director said, take off your mask, we're all good. And then Delta hit us. So we need to be careful about declaring victory. And I tell people, hey, the Braves won. Let's do a baseball analogy. We're in the 7th inning. We haven't won the game. And it's not the time to say, okay, we're done. We can now bring our second team in because this is our game. No, we actually have to really bring our best closer, get our best batters, because in order to win the game, you got to go until the last inning at the last out. And we cannot give up right now. And I think we sometimes tend to want this to be over. We're all tired. We all want this to be over. But the reality is it's not over.
I agree. We all do want it to be over, but being tired of it does not mean the virus is done with us. And I do appreciate your Braves analogy with our World Series Braves that we had. And if any city has ever learned that you can't stop until the very last out, it would be the Atlanta sports teams for sure. And with 1,200 deaths a day, we're still, way too high, and so much higher than what you would suggest is potentially a comfortable level of learning to live with this COVID-19. So for all of you watching today, please remember to stay safe and healthy through Thanksgiving. We are not out of this COVID-19 pandemic yet. We have made incredible strides, and the news of vaccines for 5 to 11-year-olds is one of the most incredible advancements that we have seen lately with COVID-19. Dr. Del Rio, thank you so much for joining me as always today to discuss everything about COVID-19. I really appreciate your insights and your time.
Delighted to be with you.
Thank you.